Dr. Abhijith. I'm a fellow in geriatric oncology at the Department of Medical Oncology in Tata Memorial Hospital. I'll be presenting our study protocol, which is randomized phase 3 clinical trial evaluating the non-inferiority of reduced dose chemotherapy take regimens based on CARG risk scores compared to standard dose in older patients with advanced esophageal, esophagogastric, gastric, and biliary tract cancer, or CARGO study. So the CARG risk score was developed by Huria and colleagues, which is an easy to use tool to predict significant chemo-related toxicities, grading between grade 3 to 5 among older North American adults aged 65 years and above. The investigators identified a significant increase in grade 3 to 5 toxicity from low risk of 30% to intermediate risk of 52 and high risk of 83%. So among 500 patients, they identified 11 variables and the score ranges between 0 to 19, with 0 to 5 being low risk, 6 to 9 intermediate risk, and 10 and above high risk. And the score is calculated prior to initiating new chemotherapeutic regimens. The factor variables include age, cancer type, chemotherapy dosing, as well as the number of agents used, physiological parameters such as hemoglobin and creatinine clearance, the functional assessment, which includes self-reported hearing impairment, fall in the past 6 months, ability to take medications, walk one block distance, and decreased social activities. A study from our center showed that a CARG did predict incidence of chemo-related toxicity, with 42% among low risk developing grade 3 to 5 toxicity, 51% in intermediate risk, and nearly 80% in high risk developing grade 3 to 5 toxicities. And when we compared CARG risk score to other parameters such as the physician-assessed ECOG performance status as well as age-adjusted Charlson's comorbidity index, we found that the latter two did not predict incident chemo-related toxicity as well as CARG. This is the go-to trial, which is a phase 3 randomized multicenter non-inferiority trial, which was conducted among elderly people who were not fit to receive full dose 3-drug chemotherapeutic agents. And they were randomized into the 3 groups in 1:1:1 ratio, with level A receiving 100% dose, level B receiving 80% of the dose, and level C receiving 60% dose. And at the end of the trial, the non-inferiority was confirmed with no significantly difference between progression-free survival between level B and level A and level C and level A. The median survival was also comparable between the 3 groups. Coming to our CARGO study, the primary endpoint is to evaluate whether reducing the dose of chemotherapy based on CARG's risk score would lead to non-inferior overall survival in patients with esophageal, gastric, and biliary tract cancers. The secondary endpoints are to evaluate if this dose reduction would lead to improved quality of life, improved percentage of patients with good overall treatment utility, decreased grade 3 to 5 toxicities, and difference in progression-free survival. So it is a phase 3 randomized control trial. The study population is patients with advanced or metastatic disease of following of esophagus, GE junction, stomach, cholangio, and gallbladder, age of more than equal to 65. And for those between 60 to 64, if they have a G8 score of less than 14, they will be included. ECOG performance status between 0 to 2, patients who give consent, and also with adequate end organ function to receive chemotherapeutic agents. So these are the treatment regimens and the standard dosings, which will be using. And in order to assess the aspects like quality of life adequately to capture the evaluation of treatment modalities, it was a focus to investigators who came up with the OTU, which incorporates objective and subjective measures of anti-cancer efficacy, tolerability, and acceptability, which includes 2 parts. One is the physician assessment and the other was the patient assessment. In the physician assessment, 2 things are looked into. One is the clinical benefit, which is both radiological progression-free as well as clinical deterioration. And for tolerability and acceptance, that is the incidence of any serious adverse events or grade 3 non-hematological toxicities. For the patient assessment part, the 2 questions are asked, which is how much has your treatment interfered with your normal daily activities, as well as how worthwhile do you think your treatment has been. And the response is over the Likert scale, which is not applicable, not at all, little, quite a bit, and very much. And the OTU is categorized into 3 groups, that is good, intermediate, and poor overall treatment utility. So this is the cargo study design, where we'll be including patients with advanced metastatic squamous cell or adenocarcinoma of esophagus, stomach, G junction, and biliary tract, and PS0 to 2, and age more than equal to 60. They'll be randomized in 1:1 fashion into arm A, which will be the standard arm, where they'll receive chemotherapy at 100% dose, and the arm B, which the dosing will be based on the CARG risk score, which will be calculated. And those with low risk will receive 100%, with intermediates will receive 80%, and high risk will receive 60%. And the primary endpoint is non-inferior or overall survival. So for sample size calculation, previously published data shows that 12-month overall survival with standard treatment in esophageal, GE junction, gastric, and biliary tract cancer is approximately 33%. Assuming that the CARG assessed dose modified cohort will not have a 12-month OS less than 30, a randomized study with a power of 80% and an alpha of 0.05 with an inferiority margin of 15% will require 372 patients. Assuming a 10% attrition rate, our total sample size would be 410. And the accrual period will be 5 years, followed by 1 year of follow-up. So this is the study schedule in which patients will undergo, along with their detailed assess evaluation, they'll undergo.
That's okay, I think. You can come to your conclusion. That's fine.
Okay, sir. Okay, sir. So this is the statistical analysis part, where it will be based on intention to treat, and received any patients who have received even 1 dose or more will be included. And feasibility in between 2019 to 2021 in our institute, we have had nearly 30,000 patients above the age of 60 and above, and among them patients with advanced esophagus, GE junction, or gastric, and biliary tract tumors have been around nearly 3,000.
That's okay. Abhijit, that also
yes,
can
sir.
skip next slide.
Yes, sir. So the impact of this study would be that if the GO2 trial results are found to be similar, then we'll have nearly 450 fewer grade 3 to or higher chemo-related toxicity, and we may have nearly 390 fewer treatment terminations in this patients with advanced tumors. Thank you very much.